Well, why don't we go ahead and get started? We got a special guest today, Fred Sherman, Professor of Medicine and Professor in the Department of Geriatrics at Mount Sinai in New York. And I don't recall that we've ever had a formal presentation on the P.A.C.E program, which he's going to give us today, and I know I'm looking forward to it. I see some people who have discussed interest in this kind of program in the past, so I'm sure Fred will enlighten all of us. And I hope most of you will be at our aging conference tomorrow, when Fred will be speaking for the 5th time in 3 days here in San Antonio. So it's been a pleasure to get to meet you, and looking forward to at least your 3rd and your 5th talk.
Okay, thank you. Thank you. I'd like to talk to you about managed care in the elderly. This is what I'd like to talk to you about. And in talking to you about that, I'd like to talk to you about, do you have a pointer inside? Is there a, Mike, yes. Is there a pointer?
Yeah, I'll get you.
To have a, to talk to you about managed long-term care in the elderly.
The lights and I'll get the pointer.
Managed long-term care in the elderly, and also talk to you about P.A.C.E programs, which stands for Program for All-Inclusive Care of the Elderly. How I got interested in this, I'm actually the medical director of a managed long-term care program, which is called Senior Health Partners in East Harlem, New York. We are going to become a P.A.C.E program, in addition to being a managed long-term care program. So what it's allowed me to do in this process over the past 5 years is to look intensively at the program that is called P.A.C.E and how that'll work in our marketplace, and also to actually develop a single capitated Medicaid managed long-term care program. So let's talk about some nomenclature first. This is Mount Sinai Medical Center. It doesn't compare in size to yours. I'm amazed at how many hospitals there are in this town, but I guess there's a lot in New York. Actually, the only difference between San Antonio and New York, I'm going to tell you right now, is I didn't bring collar stays for my collars. I'm going to flip up during the presentation. And in New York, I could go to my dry cleaner or my laundryman, and he has stays. But I was driving around San Antonio this morning with Sandra Riley's husband, and we stopped at a bunch of cleaners, and we went to this one cleaner. He said he doesn't have these stays. I should go to Walmart to get the stays. So that's probably the only difference between San Antonio and New York. Anyway, let me go back. This is Mount Sinai. We're at roughly 96th or 98th and Madison Avenue in New York City, and on 5th Avenue, which goes along the park. This is Central Park. But if you sort of walk north from there, you start walking to East Harlem, and this is Harlem Mere, which is at about 110th Street. It's actually a very pretty part of Central Park in New York City, and our center is at 107th, right near Harlem Mere. And so the issue is, P.A.C.E programs they cost a lot of money. I think that's one issue that we better get right out here, because you need money to to build a center, to hire the people, to have in place before anybody gets there. So there's a fair amount of fixed cost in it. So the issue is, if you want to become a P.A.C.E program and take care of dually eligible Medicaid and Medicare older adults, who are both Medicare and Medicaid, and you want to manage them intensively, which is what P.A.C.E does, and you want to be capitated, which is what P.A.C.E does, which gives you a capitated payment every month to care for these people, and you want to be responsible for, and you want to be responsible for all their acute and long-term care, and you want to micromanage them 24 hours a day, 7 days a week. You need somebody to give you the money to do this, and eventually what happens over years, you end up paying them back once you generate savings from the program that you're doing. So the issue is, who sponsors you? Better be put out the table first, because if you're considering one of these programs, you have to line up sponsors. It's anywhere between $2 and $4 million you have to do it. In our particular situation, well, here's, if you look around the country at the other P.A.C.E programs, these are the kinds of sponsors they've sought. In our particular case, we're sponsored by 3 not-for-profit organizations in the city of New York: Mount Sinai Medical Center, the Jewish Home and Hospital, and an organization called Metropolitan Coordinating Council. So if you walk further, this is our transportation that we contract with and our vans that bring the older adults back and forth to our program. Here's our site. And the reason I put these slides up front is I want to give you something visual to hang on to, so you can see where we give our service, the kinds of service we give, the oversight we have to have on these the service delivery system, and then and understand our financial model as well and our clinical care model. So I thought some pictures of the place would be good. So actually we're downstairs, we're in a Mitchell-Lama building, which is a middle-class housing project in New York City, and we're down in the basement down below. And if you walked in at the middle of the day, it would look like a senior citizen center. You'd see a bunch of old people, some in wheelchairs, all dressed. They're not in any gowns. They all live at home. And they'd be eating lunch or having some recreation activity. And if I took you on a tour, you'd see that around that room are all of the makings of an organization that emphasizes functional recovery and tries to keep them at home. So there's physical therapy, there's occupational therapy, there's a medical clinic there, there's recreation, and there's a care management team. Now, the care management team in our program at this point consists of a nurse, a social worker, and a scheduling coordinator. And they're responsible for anywhere between 70 and 90. We're trying to move that 90 figure down, older adults. And this is just the entrance to it. And I'll describe to you the levels of disability that we have and what we do. So the little history is important. I think that P.A.C.E is not a new program. It's been around for some time. It started in the early 70s in On Lock, San Francisco. There, the Chinese families didn't want to have their relatives go to a nursing home, so they decided to essentially offer them daycare. That daycare concept expanded into a 24-hour, 7-day-a-week program. And their program is now the second largest P.A.C.E program in the country. The largest P.A.C.E program in the country, ironically enough, is just 3 blocks from us. And it's CCM, which is Comprehensive Care Management, which is managed by Beth Abraham. And which makes me make the point that how P.A.C.E programs, which is a duly capitated program, that is that you get a capitated payment for Medicaid and a capitated payment for Medicare, is competitive with a single capitated program, which is where you just get capitation from Medicaid, and which is what we are currently. And we're 3 blocks away from each other, so we're a very highly competitive arena where we are in New York City and in East Harlem. Whereas other programs, which may be the only program in town, which is if you decided to do this in your town, you'd be the only program in town, you have the competition isn't there. So that probably is good for you. They became a demonstration project in the late 70s, early 80s. Dual waivers meant that they got the feds to give them a capitated payment, which means that every month, at the beginning of the month, the federal government gives them a payment for the care for all acute activities, and the state government gives you a payment for all long-term activities. You put that in one basket, and you're responsible for everything that goes on. So if the patient goes into a nursing home, goes into a hospital, goes to the emergency room, the hospital will bill you for the services. You become Medicare. If the participant goes into a nursing home, then you have a contract with the nursing home, and the nursing home bills you. You become Medicaid. So the good news about this is that you can spend the money any way you want. You don't have to follow any federal restrictions. They don't have to be 3 days in a nursing home, skilled nursing, or 3 days in a hospital before they go into a skilled nursing facility. You just buy services. You contract and you buy services. So that gives you the freedom that they talk about. Patient participant, needs an air conditioner. They need steps. They need to have their apartment redone so that they have so it's safe to get in and out of the bathroom. They need to have the thing cleaned up. Whatever it is, just spend the money. It's there. That's you use the money to spend the money to try to improve the participants' health care and prevent them from becoming frail and prevent them from getting any disability. So you spend money up front, which is good. In our program, like in all managed care, we spend money to save money. It's really true in this. We're trying to do primary, secondary, tertiary prevention in a very aggressive manner with very frail older people, as opposed to fee-for-service where you spend money to make money. So P.A.C.E was formalized in '86. The first site waivers, of which ONLOC and CCM, Comprehensive Care Management, as well as ILS, which is in Rochester, and a bunch of others, were first waived was in 1990, and then actual legislation went in 1997. So, as I said, you have PACE, Program for All-Inclusive Care of the Elderly. The first site was on Lock. Now, I want to differentiate between dual cap programs where you have to understand the financial model and you have to understand the care model. The financial model is important because we are both a health provider, which is we provide care, and we're also a health insurer. And in fact, my program is licensed by the Department of Insurance in the state of New York and by the Department of Health. So we have two organizations from the state oversighting us. And when we become a PACE program, we'll have a third organization oversighting us, which is the federal government. So there's a lot of regulation involved in these things, and it's a lot of work that you have to put in. So right now, let me continue with the terminology issue, because if you're a single capitated Medicaid program, which is what we are, in New York State that's called a managed long-term care program. Nationally they talk about that as pre-PACE, which means you take on the Medicaid capitation, you work with that for X number of years, and you apply to the federal government, and through your state, that ushers the application through to the feds. And then if that's approved, you then become a full-fledged PACE program, which means you take on full capitation for both Medicaid and Medicare. Where we are in the process is we're one of the 15 managed long-term care programs in the state of New York, 5 of which are considered PACE, 1 of which is pre-PACE, and that's us. And the other, the other 9 are probably going to remain just single capitated Medicaid programs. What's the difference? Well, as I said, in the PACE program, you're responsible for all acute and long-term care, and you get the money from the federal and the state government to do that, and you are Medicare and Medicaid. In the single capitated Medicaid program, which is what we are, you're responsible for all long-term care needs. So you have people who are over the age in our program of 55 who live in Manhattan. All PACE programs have a service delivery area. We live in Manhattan. They're nursing home eligible in the state of New York. Now, if the program was here, they'd have to be nursing home eligible in the state of Texas. But they're nursing home eligible, which means that they score at a certain level of disability on whatever forms you guys use. We have our forms in New York State. And, but here's the hooker. They don't want to go to a nursing home. So they're nursing home eligible, and they don't want to go to a nursing home, and they have Medicaid or Medicaid eligible. So they are poor old people. They're poor old people. That's why they're on Medicaid. All right. So what comes with poverty and old age is a whole bunch of problems. So you're dealing with a much sicker group of people, by definition, than if they were not poor. All right. So now what Governor P.A.C.E in the state of New York does is every morning he wakes up and he gives me and my organization $145 for each of these patients. And he says, Fred, I want you to do what I told you, what you said you were going to do. You're going to try to, every day, you're going to try to keep them out of a nursing home. That's the passion you should have. Right? And you can do that through this care management system that you've set in place. And guess what? If you luck out and they get sick and disabled, because they're nursing home eligible to begin with. They're nursing home. If you luck out and they have to go to a nursing home, you pay the nursing home. That's the deal. It's a lifelong program. You can't say, well, you're going to a nursing home, we're going to disenroll you. We can't take care of you. No, that's not the deal. And if you try to disenroll them, we're going to come after you. So it's a lifelong program, the Medicaid capitated program that we run. So how much is the cost of the nursing home in New York City? $185 a day is the cheapest we can find that's of the quality we want. One of our sponsors is actually a nursing home system. They charge us $235 a day for one of their sites and $250 a day for their site. So we're only getting $145 from George every morning. So you can already see that we're highly incentivized to try to fulfill his passion, which is to keep these people out of a nursing home, and our passion, which is the same thing. So in managed care lingo, they talk about goals being aligned. Our goals are aligned. Now, the reason this is such a good program is because for geriatricians and for geriatrics, this is the ideal playing field to be in, I think, because you have to really be good at this. You really have to be good at geriatrics, because many of these decisions that we have to make, that you make, are great decisions. You have to be willing to take risk in these situations, where your best judgment is that if we provide X number of home care hours, these people can stay out of a nursing home, and we can, we can do all kinds of things to try to keep them from deteriorating, going to hospital, and keep them out of a nursing home, because that's where we get, where they don't want to go, and we have to pay big time. So the issue is, does the care model work to do that, to give them a optimum level of care, or certainly the highest quality of care we can give them. Now, why is George Pataki interested in this program? Well, George thinks that we save him between 5 and 15% on a comparable nursing home patient. So that's why the government's interested in this. Why is George Bush into this program? Because he pays us 5% less than he pays for comparable Medicare patients. So both the federal and the state government, from a fiscal point of view, are interested in this. And I would say going forward that this may be one of the components that will help save the state the state Medicaid budgets, which are all in trouble. As I said, we're in a very competitive marketplace, which is Manhattan and New York City. There are 7 managed long-term care programs in New York City. So this is different than any other marketplace in the country. When I give this presentation to my other medical director colleagues in programs, they don't know what I'm talking about because they're the only game in town. We're not the only game in town. The Visiting Nurse Service in New York has a program that has about 3,000 people in it, which is just a single Medicaid capitated program. Our program has about 450 people in it now. Now, let's just put PACE in perspective. All right, been around for a long time. There's only 10,000 people in it in the country. It's not a big program. All right, why is it not a big program? Why is it not a big program? Well, because when you go into a PACE program, everybody, this is a good state to talk about this in, everybody wants choice. I mean, if you don't like it, you're going to do something down here. So people want choice. They want to keep their own doctor. They want to keep their own specialists. They love their pharmacists, apparently. They want to keep their own home health aide. And you say, well, if you come into PACE program, guess what? We have a limited list of providers. I'm going to be your doctor. The nurse practitioner here is going to work with me. We're going to take care of you. That's it. You're going to have to give up your doctor you've known for 30 years. Okay? And if you get sick and we need a cardiologist, this bright young cardiologist I've hired from Mount Sinai is going to be there. He likes geriatrics. He studied it. He seems to know what he's doing. He's our guy, not the cardiologist you know. And guess what? If you get sick and you have to go to a nursing home, you have to go to a hospital, you come to Mount Sinai. Oh my God, I hate Mount Sinai. Oh, that's the deal. If you have to go to a nursing home, we've contracted with 3 nursing homes. That's it. That's where you go. That's why PACE doesn't enroll extensively like it should. That's why this program has stayed small, in my opinion, not ramped up, because choice is limited. Typically, they enroll at a very low rate. The single capitated product, which is what we have now, I sort of use this managed care lingo, but that's what it is. The single capitated Medicaid-only product. There, you can keep your doctor, you can keep your hospital, everything that Medicare pays for, you can keep. You can go to all your specialists. You can do whatever you want. But if you need a nursing home, we're going to send you to our nursing home. All right. If you need podiatry, optometry, dentistry, or audiology, or home care, you're going to go to our providers. That's the limitation. All right. So the single capitated, that's why in our marketplace, the Medicaid-only capitated long-term program actually works best, because people want choice in New York City at least. So once again, the PACE model allows you to honor the frail elderly who want to stay in a familiar environment. They want to stay at home. They want to maintain autonomous. And many of their families don't want to go to a nursing home. They don't want to go to a nursing home. And it's our job and their job to maintain them at maximum level of social, cognitive, and physical function. Now, I made this slide up this morning because I think that it's important to think about dual eligibles. I'm sorry there's so much on it, but let me just give you a sense of what dual eligibles. Once again, they have Medicaid and Medicare. That's the lingo for dual eligibles. All right. Let me just tell you a little bit about them. There's 55 million Medicaid enrollees in this country, of which 7.5 are dual eligibles. That's about 14%. And 4.9 of those dual eligibles, 4.9 million of them, or 9% of the total, roughly 10% are over the age of 65. Which is about, it's a little bit less than what the population has over the age of 65 is compared to the total population. Most of them are low-income individuals, as I said. So 3/4 have annual incomes of less than $10,000, compared to only 12% of all Medicare beneficiaries. All right. 20% live in nursing homes currently, compared to 3% of Medicare beneficiaries over the age of 65. 50% claim that they have fair or poor health if you ask them, which is 2 times the Medicare rate. A third have significant limitations in ADL, 3 times the rate of the Medicare population at large. Now, I did a little work for you here in Texas. 97% of the aged enrollees in Medicaid in Texas are aged dual eligibles. 97% of the elderly who are on Medicaid rolls in Texas are age dual eligibles. So you got a lot of them here. You got 365,000 roughly. And here's the clinker. And this is why you want to think about what you do here in this state. Because the state currently is paying for those dual eligibles roughly a little bit less than $10,000 a year. In New York State, we get $25,000 from Medicaid. So it's a rich program where we are, and the issue is whether the Medicaid component, because the governor's going to want to save money on it. He's going to bring you in at $9,000, $9,500, and try to save 5%. So that's why you got to think of whether you can do this program for that. Now, why do they like this program? Because 70% of Medicaid dollars on dual eligibles is spent in long-term care. And of that, 2/3 is spent in nursing home care. So the state governments see dual eligibles as being sicker, requiring more long-term care, requiring a lot of nursing home care, which they pay the budget for, and so they want them out of nursing home. They want them out of nursing home. All right? Only 25% of the long-term care monies that I mentioned above are for home and community-based care. 2/3 is for nursing home care. So that's the conundrum the states are in. That's why these programs are being sought after, in my opinion. And that's why it's a growth area. The issue is whether a PACE program or a single cap, a dual cap or a single cap is for you. Let's compare fee-for-service with capitation. Capitation means that every morning, it's not every morning, it's the first of every month. The reason I say $145 is because if you actually say $4,350 per month, people say, well, that's a lot of money. You're getting a lot of money. But when you say $145 per day, which is what we get, and I say that we provide all their home care, all their drugs, this is the single cap Medicaid program, all their drugs, all their home care, all their podiatry, optometry, dentistry, audiology, all their transportation services to and from doctors. We provide everything that Medicare does not. And if they go into a nursing home, we pay the nursing home. $145 a day. People say, my God, how can you do that? All right. So now, in fee-for-service, what are the problems? Well, the problems are what you guys live with and what I live with in my other life. It's fragmented. You know, I have to deal with the hospital, I have to deal with the subacute setting, I have to deal with the nursing home, I have to make sure the transitions go well, I have to deal with multiple providers all over the place, I have to deal with multiple consultants. It's certainly discontinuous. It's a high-risk area for errors. Those transitions between institutions are the areas where errors get made. And one of the reasons it's discontinuous is because of the financing mechanisms are very different. Long-term care settings paid for through Medicaid mainly, subacutes paid for through the feds in part. It's paid privately, and there's a whole bunch of restrictions. That's fee-for-service. And then, as a physician, do I follow the patient in the hospital? Well, no, we have hospitalists. I don't have to see them there. I saw them in the office. Now, do I have to see them in the nursing home? Probably not. It's too far away from my office, so I don't see them there. So essentially, I've lost the patient until they get discharged. They come back in my office, and I see them again 6 months later after their stroke or whatever. So there's a whole bunch of discontinuities that we live with in this country. All right. Now, in PACE, it's the land of integration. All right. Everything's integrated. I'm the doctor. I'm the family doctor. I'm the doctor for the 180 patients we're going to have, and that's it. I work with a nurse practitioner. I'll probably hire another nurse practitioner or maybe another physician, but that's it. It's like a group practice taking care of 180 people. If they don't like me, they better find somebody else. I take care of them in the outpatient setting, in the inpatient setting, in the long-term care setting. I take care of them in all sites. I don't franchise this out. I'm the doctor. All right. So what transitions there are, I have to try to smooth out as much as possible because I know that errors are made at the transitions. The financing is integrated. That is, I get the money every morning. I get the money for the long-term care component and the acute component, and everybody bills me. So there's no issue about how this is paid for. I'm at full risk, and there's no restrictions on how I spend the money. So if they need an air conditioner, if they need steps, if they need a personal emergency response system, if they need whatever they need to try to maintain their health at an optimal level, we'll spend the money on. All right? Sounds good, huh? Okay. So who's eligible? And once again, I've gone through some of this before. They're over the age of 55. They're nursing home certified in your state. They live within your service area, which in our case is Manhattan. Now, here's the clincher. You have to provide a care plan, and whether you're a single cap, Medicaid only program, responsible for long-term care, or you're a dual cap program, PACE, you still have to come up with this safe concept. They have to be safe in the community. All right? Now, the problem where I work is that, the families come, they're all interested in helping out, and then we take them on and they're gone. or they may be going, or they may not be able to keep up with what their end of the bargain was because of illness, because of job responsibilities, because of social issues, etc. We've taken them on. We have to continue to provide a safe care plan for them. So we have to step up the services that we give them if the family doesn't hold on to their end of the bargain. Not too different than private practice in general. P.A.C.E, as I said, are dually eligible, and that means that the Medicaid and Medicare components are paid to us, and it also means the level of disability that I told you about. They're sicker people, all right? They're sicker, they're frailer, and they've gotten poor medical care in the past. Let's look at typical P.A.C.E enrollees, all right? Mean age 80, 3/4 are women. Once again, it's a nursing home population, a little bit younger and a little less frail, I think. Average number of basic ADL impairments are 3.5 to 4. 2/3 have cognitive impairment, and their average life expectancy is 4.5 years. So it's a disabled nursing home population or pseudo-nursing home population. Their illnesses, these are prevalence data, and so this is no surprise either. It's interesting the dementia data is different in this slide than the 2/3 that I quote because of the way that the data is gathered, but it's somewhere between 50 and 60% have dementia. And so this is no surprise. There's a lot of potential for reversibility here with the studies that we have available. There's a lot of illnesses here that are treatable, and so there's a lot you can do for these people. As I said yesterday, I'd never met an older adult for whom I could not do something, and the same thing applies for all of these people who are coming into P.A.C.E and pre-P.A.C.E programs. What are the services we provide? Just to go over, I told you if I walked you into the center, you'd see all these old people sitting around eating lunch. These are the services that surround them, all right? This is what we're responsible for in a full-fledged P.A.C.E program, all of these things. And so you can see that integration is the name of the game. I mean, you're all in the same building, you're all on the same site, so the ability to communicate is there, the chance to communicate is there, and you have to communicate well with all the other team members that are involved in this. It's one big, sometimes happy, sometimes dysfunctional team that runs these programs. So primary care is myself and perhaps another physician or nurse practitioner. We have nurses in our day center. We run a diagnostic and treatment center on site in the program. So if somebody gets sick, or somebody needs to be seen and evaluated on a routine basis, every 120 days or every 180 days we see them. If they get sick or have a syncopal episode, we see them right away. We run, it's like an urgent center actually. The beauty of P.A.C.E is that you can bring them back into the diagnostic and treatment center, and you can treat them with intravenous antibiotics, you can treat them with IV hydration. You can do a lot of things that are exciting in geriatrics to do, but allow you to keep them away from the emergency room, because they don't want to go to the emergency room, because now the emergency room leads to the hospital, and the hospital leads to the nursing home. So they know all that. The daughters don't want to go there. They know that we can take care of that in the diagnostic and treatment center and in our urgent care center. So that's what we do. So it's exciting geriatric medicine. It's exciting for the nursing staff, for the medical staff, for the social work staff. There's a lot happening because you're not only doing long-term care in the community, long-term care institutional work, you're doing subacute and acute care as well, and you're doing urgent care. So there's a lot happening. We have a rehabilitation center there, and then we have these other services that we provide and these other team members that join our team meetings. Team meetings are big. Let me see who's there. Actually, the NPA designed this slide, the National P.A.C.E Association, so they're trying to be politically correct. So they put the social worker at the head of the table, and for obscure reasons, it didn't make the table round. But whatever the case may be, I just want to be politically correct. There you go. So it's one big happy team. The problem actually in doing this that I've realized in this particular team is that you really want to hire people who have training in gerontology and geriatrics. Now that may sound obvious. I made that point yesterday when I talked about acute care of the elderly units in the hospital, that you don't want the head of nursing and medicine to say, as they did to me once upon a time, well, you can have this unit and you'll take this nursing staff. And I had a nursing staff that was dysfunctional. They really didn't want to take care of the elderly, yet this was going to be a unit that was devoted to the elderly. It's hard to hire people in New York City who have training in gerontology and geriatrics and want to work in our kind of program. So we've had to hire people who have just training in adult social work or general adult social work or general adult nursing who have had it. And that creates problems because they don't know the body of knowledge that's gerontology and geriatrics that applies to their field. They don't know it. So you have to teach it to them. And so it's a lot of responsibility. And in the process between time zero when they don't know it and when they finally do know it, they make mistakes. And so you have to have a fair amount of oversight to prevent errors during that window. You have to watch it. So what is the network in the PACE program that we contract with? So, for example, we contract with about 15 home health agencies in the city of New York. Because one reason, in our particular program, for example, some PACE sites are home care agencies. They're CHA, they have a CHA, a certified home health agency. They are a CHA. Right? And so it's integrated into them. We're neither a CHA nor a licensed home health agency. We're neither of them. So we have to contract with the 15 or 20, and it's a growing number of home health agencies. Because what happens is somebody looks at our program and they say they have this home health aide. They have a home health aide that they've had for 2 years. And they say, well, if you come to our program, you have to give up your home health aide and you have to take on our home health aides that we contract with. They say, I don't want to come. I want to keep my home health aide. I'm not coming to your program. So what we do is we say, fine, you want to keep your home health aide? We'll contract with your home health aide, ABC, and you can keep your aide. That's the only way we can get them into our program. And so we contract with 15 to 20 home health agencies, and the problem is, as the medical director, to provide quality oversight to 15 or 20 of anything. Like, I don't know, it's pharmacies, home health agencies, whatever it is, doctors, nurses, it's very difficult. The good news is we have about 3 or 4 agencies that take care of most of our patients. We call them participants, actually. Most of our participants. And I can bring them to quality utilization management meetings, and I could demand a certain level of quality out of them, as opposed to those agencies that have 1 or 2 of our participants who will never be able to get in front of me. So I wait for incidents and events to happen out there, and then I talk to those small mom and pop agencies, whereas the 2 to 3 primary providers of home care, they're at our quality meetings all the time. We bring problems to them all the time, and they correct us. We contract with Mount Sinai Hospital, all right, which is one of our sponsors. We have a pharmacy benefit management organization that we work with called PharmaCare, because what happens is the older person doesn't want to get their drugs from a new pharmacist. They want to go to their pharmacist, who they supposedly hold in greater respect than probably anybody else in this room. Neither nurses nor doctors nor social workers in any way compare with the esteem that pharmacists are held in by older people. So we contract with a large pharmacy benefit management program that has 5,000 pharmacies in New York City or New York State. And so anytime they walk in with one of our cards, it goes through their computer and they can use the regular pharmacist. As I said, we contract with 2 or 3 nursing homes. We contract with DME. All of these things we contract with. So it requires a fair amount of oversight. What are the advantages of the PACE Center? Then we have a center where we bring them back and forth in those vans you saw. And why do we do that? I mean, because some of the people like socialization. Well, the problem is it's a fairly expensive concept, socialization. It's a fairly expensive thing to do. My position is that we only bring them back and forth if we need to observe them. That is, that this dining room is really a micro-observatory where we observe old, frail people, and we bring them in because we think something's happening to them and they're dynamic, they're changing. We train our aides to look for the speed with which the participants blink their eyes, because sometimes we pick up these subsyndromal deliriums where they just blink a little bit slower, or they maybe move the food to their mouth a little bit slower. I mean, our aides know these people well, and so we tell them that if that happens, something's wrong. You better bring it to somebody's attention. And we bring them into this observatory to do this. And sometimes we pick up things that I'm not sure I know what to do with. They're so early. I mean, it's so subsyndromal, I'm not sure what's going on. They're just slowing down a little bit. Maybe it's just this, or maybe there's something that's going down that we picked up in a very early stage. So we observe them. It's a micro laboratory, it's frequent observation, and that's the way you manage these people, because the way you keep them out of the hospital and you keep them out of the nursing home is you have to micromanage them. And you have to do real-time medicine. I mean, it's not like, if you think about what happens in an outpatient setting, you see the little old lady who should be in a nursing home, you see her every 3 or 4 months, all right? You hope her daughter, you see her, you change her medicines, you do whatever you do, and you hope when she comes back in 3 or 4 months, everything's fine. You have no way of observing that. You assume the daughter will call you if there's a problem, or the home health aide will call you. In a PACE program, you're bringing them back to the center 2 to 3 times a week. So you're observing them fairly frequently. And you could bring them back 5, 7 times a week if your center's open 7 days a week to observe them. Or you can send the home health aide or the nurse out to observe them frequently and give you feedback. My observations are, if you bring them to the center, you have much more reliable data than if you keep them out in the community. It's just that you have to put them in a van and bring them in. I tend, with the data that we now have on home-based improvement in depression, home-based exercise programs, home-based treatment for Alzheimer's victims, some of which I showed you yesterday, I'm hard-pressed to bring these people into the center for socialization, because we can actually, there's good data that you can provide services in the home that will prevent depression in older people, that will treat demented symptomatology, that both the caregiver will be pleased with and the old lady will be pleased with, and not bring them into the center. So I'm in a minority in my organization because everybody wants to bring them in for this concept of socialization, and I really don't. So we pick up these subtle mental and physical changes, and we got to do something about it. So that's the beauty of the center, in my opinion. Otherwise, you have multiple members of the team can observe the participant, make comments, and all right. We have a full-service diagnostic and treatment center in the center. We have an urgent care center there. We can give IV antibiotics. We can monitor them frequently. You can avoid the emergency room is the name of the game. And then if they want, they can use it for socialization. This just says the same thing a different way. Face-to-face. That's the beauty of the team. We're in the same building, and we're there, the whole workday. So I try to avoid email as much as possible because I actually walk down and talk to my collegial team members because I think it needs to be dealt with face-to-face because it sets a set for urgency. Also, it's real time. I mean, if we have a problem, we can move on it quickly. We don't have to wait for anything else to transpire. Because we know that if we don't move on it, it's going to end up affecting us in a negative way. The participant's health is going to decline. We're going to end up going to a high-cost area. We're going to have to pay for it, and we're going to have to pay for a mistake because we didn't see the subtle perturbation back at time 1 or 2. So the team issues are information sharing, education, problem solving, care planning, and outcome monitoring. We spend more on community-based care so we can spend less on hospital care and nursing home care. So we'll invest money in the community. We'll put 24/7 in the home if we think it's indicated. We don't do it for a long time, but we'll do it. We very tightly follow, as I'll show you data, our utilization of certain expenses because there are our most costly variable expense, for example, is home care. Our most costly fixed expense happens to be the cost of running that center. Every morning we open it up, we have to pay for the electricity, we have to rent the space, we have to pay for all the staff. So the center becomes a very costly fixed expense. Where are all these old people? If we're supposed to keep them out of a nursing home, where are they all? Well, nationally, about 80% are in the community. That's where they should be. About 15% are in foster or group homes, and that's mainly because in the state of Washington and other places they have these foster and group homes. And 5 to 7% are in skilled nursing facilities or long-term care at any one time. Now, once again, these are dually eligible people, so that they're both poor and old. And so this is the makeup of our programs in terms of ethnic backgrounds. And let's see where we have Hispanic Americans. And we have the 21% there. That's mainly because there's a program in El Paso. Is there any other one in the state? Anybody know any other programs? There's one in El Paso? I know that one. So there's 2 or 3 in Massachusetts, I think 3 or 4 in Massachusetts, full-fledged PACE programs, but the competition isn't anywhere near what it is for us. Let's talk about their ADL deficits so you get a sense for how disabled they are. They're roughly 75 to 80% of them have the bathing, dressing, walking ADL impairments and need assistance, and about a third need assistance with feeding. In terms of IADL impairment, it's pretty heavy duty, mainly because of the burden of dementia that these people carry, plus the physical impairments they have in late life. So it looks like a fairly typical nursing home population. Now, you're in a dilemma in these programs as to, as a clinician, what exactly you should be doing. If you're a good geriatrician, you're trying to manage all these problems at once, and what most of the medical directors, all the medical directors and I have realized is that there's no guidelines that we can follow in this program by and large. That it's hard, and I think that the JAMA article that I discussed yesterday by Boyd and the Bolts at Johns Hopkins and Linda Fried clearly point out, and that patient that they discussed, the 79-year-old female who has hypertension, type 2 diabetes, COPD, and two other chronic illnesses that I can't remember. It wasn't atrial fibrillation, it wasn't depression, it wasn't dementia. But if you add those things to it, then you start to talk about a patient like we care for in our program, and the burden of trying to put these 5 clinical guidelines together in a way that was functional turns out to be dysfunctional. So I think we just give good geriatric care with the caveats that we micromanage these people. We respond real time. And those two things are very important, and they're not often talked about in geriatrics. Any perturbation is looked at and analyzed and managed in a timely fashion. There's no waiting. We're only waiting if we make a decision that we don't know what to do with it. Right? And that's different than the episodic interventions in outpatient medicine. And the observers are not the daughter. As I said, the observers are all our team members. So let's talk about some of the challenges that we have in these PACE and pre-PACE and managed long-term care programs. We begin to think in terms of total management of the individual as opposed to sentinel events. I mean, if I wait for sentinel events to happen, I got a problem. All right. So I try not to wait for sentinel events. All safety, as you know, is the future, and so if we're looking at these people real time, hopefully we will prevent safety issues from occurring during the future. And that's through micromanaging each case. Anybody read the book Good to Great? Good to Great? It has nothing to do with medicine. It's a book about the business school, Stanford Business School. The dean and I think some of his students did a research study of the Fortune 500 companies, of which I think there's 3,000. And they looked at the ones during the 1990s who had a very extended and large rate of growth, larger than anybody else. And they found there were only 10 of them. There were 10 companies that went from good to great. And so what they did was they analyzed their management, they analyzed their hiring and firing practices, they analyzed their CEOs, there were only 10 of them, and they analyzed just about everything you can about these companies. And they began to look at them and why they were so successful. And these were not all, they were actually, none of them were technology stocks. So it wasn't that they were at the right time in terms of the market run-up. And what they found was that each of these, first of all, you've never heard of any of these companies, number one. Number two is you've never heard of any of their CEOs, all right? These are not Jeff Immelt, they're not any of these people. So what they found out was that each of these organizations had a passion for something. They had a passion to do something. And in our organization, we have a passion to keep people out of nursing homes. That's our passion. And the second circle that they had in these 10 great companies was that they thought they could be the best at doing it in the world. Now, I'm not that grandiose that I think we can be the best in the world at doing managed long-term care. I'll just take being the best in New York City. Right? So we think we can be the best in managed long-term care in New York City. And the third circle that has to be in place for any major decision to be made is you have to understand our economic model. So what's our economic model? Well, our economic model is based upon what I think many of us in geriatrics know and believe, but we don't practice. That is that throwing services at older people and throwing tests at older people and throwing all kinds of things, medications at older people, may be doing more harm than good. Now, I think we have an inkling in geriatrics that that's probably true. The beauty of this program is I have to practice that way. Every time I want to do something with an older adult, I have to decide whether the risks outweigh the benefits for that. And number two is, what's the evidence for it working? That's the issue. I have to do that. And if I can't make a decision on those two things, then I make a decision on my past experience to do something, and we monitor it because we're flying by the seat of our pants. The beauty of the program is you can monitor it closely. Once again, it's micromanagement. So if the team makes a decision that moves us into a gray area, we're going to monitor it very closely. I think you have to abandon the assumption that more is better. This is what I'm talking about. It's the managed care mantra, but it's the managed care mantra with a frail older population. So the risk taking is greater, and that's why, as I said before, if you do this, you got to hire people with training in gerontology and geriatrics. Don't do what we did, which we were forced to do, which was do it without it, by and large. I think you have to understand that not all of the things that you'll be doing in this population have evidence that's based on randomized controlled trials. In fact, the majority is not. And where there are randomized controlled trials, as you know, they probably don't apply to the population that you're caring for. So you have to be risk takers, and you have to try to recognize that the care plans that you're doing, you nice to have a diagram, but what happens is in an organization you have optimally therapeutic care plans that are up here, you have minimally therapeutic care plans that are down here, and time, which is going along here. And on any given moment, these care plans in terms of their safety are fluctuating in the optimally therapeutic and the minimally therapeutic area. And if they start to head downward toward the minimally therapeutic line into an unsafe care plan zone, then what we do in our organization is we shut everything down. The team that's involved with 70 or 90 participants shuts down and starts to focus on that one individual, because we know if they continue in that trajectory, they're going to go to an unsafe care plan. What the unsafe care plan means is that the patient's non-compliant with their medicines, that the patient has an unstable medical problem or psychiatric problem, that the caregivers are getting stressed and are ready to pack it all in and leave. And we can give people, because we can spend the money the way we want, we can, if a caregiver is deteriorating and isn't able to do what they said they would do, and it's understandable, we can just take the participant and put them into a nursing home for a period of 2 weeks or a month. We can put in more home health aides and tell the family go on vacation, because we value the ability of the family to remain intact and make the contribution that they make. And also, the final thing about the importance of these challenges are to embrace the importance of a consistent care delivery system over time. And so we're constantly looking at our systems and looking at redundancies in our system to make sure that errors are not made. We're trying to be like NASA. Here's where all these programs are now. I don't know. You know, here's Texas. Look at that. That's El Paso, I think. I don't know what that one is.
That's Texas Tech. That's Lubbock.
That's Lubbock. They're small, no?
Yeah.
Okay. Well, there they are. So we got 2 of them in Texas. But there's a lot of them up in the Northeast Corridor. There's a lot of them up there.
That or San Angelo.
Now, as I told you, here's the financing. Let's just go over that, because, you know, it's ideal for geriatrics, because you want to think about how you're spending money. You don't want to spend, you want to spend the right money on the right service at the right time. And actually, if you keep that, if you try to remain clinically focused, what I found is that being a medical director and being the clinician who's in charge, what I found is that everybody gives me, I have huge volumes of reports that come out about utilization, and I'll show you some of them. And, but what I learned is that by the time you get the data, it's too late. It's too late. You're managing 400 people and you're looking at pharmacy. Well, unless you make the right decision with each individual drug, by the time I get the data about how much I'm spending on drugs, it's too late. I've already done it. So you have to manage each individual patient well, and the data will follow. So I generally don't, you know, they show me the data, I don't particularly react to it, because I try to do good geriatric care, and then the data shows that. All right? I mean, naturally, we break pills in half. Naturally, we use generics. I mean, that's a no-brainer. In fact, interestingly enough, I did a study at our place. I said that, you know, we would take people who are in our program from brand name statins to generic statins, and we look for side effects, and we look for acceptance of the treatment, and we look for that we got the same outcome of LDL. So I did it. I presented this data to my colleagues, and they said, "Fred, why did you bother to study it? Why didn't you just do it?" You know, but I did it. So the concept of generics and splitting pills, etc., which is now generally accepted in many areas of healthcare, my colleagues were doing as well. Here's the median capitation in 2002, roughly $1,400, $47 a day for Medicare. And that's when we become a full PACE program, we'll get about that from the federal government as well. It's going to be risk adjusted going forward, and it's not clear how that'll happen. It's clear how it'll happen, it's not clear what the outcome will be. As far as the Medicaid capitation nationally, it's roughly about $82 a day. You can see that the New York State's very generous with us. We get $145 a day. And the methodology for reimbursement for Medicaid varies from state to state. This is essentially it. So this is the national figures. 2/3 Medicaid, 1/3 Medicare, the whole pot. All right? Is roughly $1,398 plus $1,400 plus, so it's roughly $3,900 a month from those two sources. And as I said, we do more try to do more and more community care, less and less high-cost care. So we try to avoid the emergency room, we try to avoid the hospital, avoid the nursing home, but and in order to do that, we'll spend a lot of money on other aspects of care to keep them out of those high-cost environments. So if you look at how we spend that money, the big thing to look at is the 71% of other costs. All right? And those are by and large the fixed costs at the center and the personnel for home care and skilled visits. And then we end up paying roughly 14% for nursing home care, pharmacies about 5%, etc. And so that's how we spend our money. Now let's look at what the outcome is in the mature PACE programs. These are the hospitalization rates. Now, I want you to think this is PACE programs nationally. This is all Medicare. So remember again, PACE programs average age 80 people, 3.5 deficits in ADL, 60% with cognitive impairment. All right. This is all Medicare. And this is Medicare above the age of 55 with 3 ADL deficits, just to compare. And so whatever we do in P.A.C.E program, we really able to cut down the hospitalization rate to almost to less than half of a comparable Medicare population that's 25 years younger. So we do keep people out of hospitals. That's the major way we save money. This is just another way of looking at it in terms of hospital days per year, much less in P.A.C.E programs, similar to all of Medicare. And this is just looking at Massachusetts dually eligible community long-term care program, which is a piece of data that one of my colleagues provided me with, and a P.A.C.E center that he works at. And so so that it's the on-site care team, the micromanagement, the rapid response to system perturbation of these old people, the 24-hour a day, 7-day responsibility that we have for them, that I think takes them from just dual eligibles in the state of Massachusetts to P.A.C.E participants in the state of Massachusetts. So it's those other added things that we do that bring this hospitalization rate down. Length of stay is much less because we can take them out earlier. We can take them out of the hospital because we can give them 24 hours a day, 7 days a week to get them out sooner. We could bring them to the center to complete their IV course of antibiotics. We could treat them in the center and send them home with a nurse. We can do all kinds of tricks that we can do to get them out of the hospital earlier, prevent them from going in. Only 10% of them, all of them are nursing certifiable in the state of New York and nationally, but only 10% or about that are in nursing homes at any one time. The place of death is mainly in the home. Roughly 50% are in the home, and then with a fifth in the hospital and about a third in nursing homes. I don't know what the national data is. Now, once again, I want to refresh your memory about, because the terminology gets a little screwy here. Pre-P.A.C.E means that you're going to become a P.A.C.E program. That means that you're managing the Medicaid capitation, which is what we do. And then you go through your state, through the federal government, and you apply to become a P.A.C.E program. And then you get, on the right-hand side, you get both capitation, both the federal and the state capitation. Same criteria: nursing home eligible, live in the service area, and live safely at home. The only difference is in the single cap program, to make sure that these are not subacute patients, they need at least 120 days of long-term care services. And the way I define that is they have a home health aide, or they look like they need a home health aide, or the family's stressed. Then they would be appropriate for just a single cap program. But that differentiates it from the the length of stay for a subacute rehab from a hip or a stroke. Our particular program, as I said, is sponsored by, and that's why you need, if you begin to think about P.A.C.E programs, you need sponsors. They have to ante up between $1.5 and $2 million apiece. You have to have somebody who has deep pockets at a time when most healthcare institutions don't have it, or you have to have donors from other parts of your community. We opened in June of 2001, roughly 4 years ago. We service all of Manhattan. I showed you our daycare center, and we roughly have 450 participants as of today, and we'll probably by the end of 2006 have 700. Once again, this is Eddie, who runs our van service, which we contract with. He's actually on site, so we oversight him pretty closely. These people are going home from our center that day, and that's more of our center. And when I get rammy and can't stay in, I walk out to the Harlem Mirror and look around. Now, here's some data. When we opened up, just to show you, we opened up in, I'm sorry, this is when we opened up, this is when we started accumulating data. It's a little bit scary. We were running 169 hours per member per month, which is the way we look at our data for home care. If we continued that burn rate of home care, we would have been out of business. So we had to have a crisis here. We were in crisis, and we had to have shut down our entire think tank and begin to concentrate on what to do to manage home care. And so we started to set up various types of protocols, because by and large there's no science in the home care industry. No one knows how many hours you should have for X, because we've never been studied. People have ways of approaching it. They have task-based assessments, one of which we started to use. And then once you have a number that you come up, because they need 2 hours of laundry, 2 hours for this, whatever it is, then you have to negotiate that with the family. But at any rate, we were able to control it, and so we fluctuate between roughly 110 and 115 hours of home care per member per month. And we watch that pretty closely. But once again, it's only in retrospect. My administrators like to look at this and then yell at me. But the fact is, if I'm not on top of these things and the rest of the teams aren't on top of these things, it just gets out of control. Here's our death rate. And our death rate is this. This is us. This is us right here. And we've been able to sustain that for actually 3 years. We have one of the lowest death rates of any program like it in the country. Now, part of it is, I think, because of good geriatric care, and part of it is because our patients are a little bit younger than the average. But even if you look at the younger cohorts in these pre-PACE groups, we're not the youngest. And so I think it's possibly one of the contributing factors is because they're slightly younger. Our average age is 76, and the other pre-PACE programs, their average age is 78. That, I think, is in part the reason for the lower death rate, but I think there are other factors as well. So what are the new directions? Well, as I said, these PACE programs limit choice. There's a program in Wisconsin, in Milwaukee, called the Wisconsin Partnership, and they have a waiver from the federal government. And what that waiver allows them to do is they contract with doctors in the community who say, we'll pay you X amount per month to take care of, or X amount per visit, to take care of this lady who's in our program. And you've been her doctor, you can remain her doctor, okay? But we're gonna case manage you, we're gonna send out the nurse practitioner to meet with you and our participant and talk to you about their needs. We're going to tell you what she's doing at the center. We're going to tell you what she's doing at home. But you're going to be the doctor who sits at the table, telephonically at least. All right? And that's a demonstration program because they want to find out whether that can work. And I think what they're going to find is that that doctor, who's not part of the organization, who's not hired by the PACE site, has less oversight, is less on top of what's going on, is less involved with the team, and probably spends more money. Right? So I think that's what they'll find. But once again, the reason they do this is because, as I said in the beginning, the problem with these PACE programs, they can't get people who want to come in because they want to keep their own doctor. So this is an adjustment. They say, okay, you keep your own doctor, we'll go out, we'll try to oversight the guy or girl, but, and we'll take a little loss financially, but we'll at least increase enrollment. The Massachusetts Senior Care Options is similar. The issues in PACE care are rural issues, are issues because if you bring them back and forth to the center, you have to have vans. I mean, and it takes time, and they travel a large amount of distances, and that's a big deal. So those are the kinds of things they're thinking about. There's currently 40 PACE organizations nationally in 21 states. It's roughly, as I said, about 10,000 people. And a lot of people are looking at it, but with the caveats that this is a costly affair. It requires a tremendous amount of oversight. It's a lot of work. Our program will probably be 180 participants in the PACE program, and hopefully we'll have a couple thousand in the single capitated managed Medicaid program. The things that you can't not do, you can't waive the integration, you can't waive the focus on nursing home care, you can't waive the interdisciplinary team, you can't waive the capitation, and you can't waive the fact that you're at full risk. All right, what you may be able to waive in the future in your PACE program is directly employing some of the PACE team members, like the doctor. And you may be able to franchise out or farm out some of the PACE centers and contract with them. But that's a waiver thing. This is just some history of the legislation, which I don't want to bore you with. This is the National PACE site that's available to, if you want to go. It's actually npa.org. NPA will get you there. So let me end here. I'm still standing at 1:15, yeah. But I think we should take some questions.
Yeah, I have a question.
Yes.
I would be concerned that by farming out so much, those two programs, the Massachusetts one and the other one, where they're trying to allow people more choice, is that not only do you have less control over it, but these are people who don't have necessarily enough geriatrics training, so the quality of care has a high risk of going down as well.
Well, I think that that's the skills of the medical director, and I know the medical director in Milwaukee, and she knows what she has to do. She's picking physicians picking the right physicians to do this, because otherwise she's going to end up shooting herself. So, and giving herself much more work. So she's trying to pick the right physicians, and she's trying to sense early on whether they're really going to cooperate with it, and then hopefully they'll take on more. So you have a few physicians in the community who have more and more of these patients, either under a fee-for-service arrangement or a capitation arrangement. Actually, in New York City, ironically enough, I'm on a CCM, which is my competitor. I'm actually one of their providing physicians, even though I'm the medical director of the program that does single capitated Medicaid down the law.
You're a busy guy.
Well, it's a fun thing. It's actually, I think it really requires, when you start to think about money and management and old people, it really brings out either the best or the worst in you. Any other questions? Yes, Don.
Do you use cholinesterase inhibitors?
Do we use cholinesterase inhibitors? Yeah, we use them, but we don't use a lot of them. You know, we have to decide where we're going to spend our money. And so the issue is, and this is a good question, because it goes to the question. You say, well, Fred, your business is keeping people out of nursing homes, and Don, I know the data like you do about nursing homes, about cholinesterase keeping people out of nursing homes. So when I use them is when I can't manage their symptoms, either behaviorally or pharmacologically with cheaper drugs, and they're looking like they're going to a nursing home. Then I'll pull the drug out. Maybe not a bad way to use it. Maybe not a bad way to use it, as opposed to keeping the drug chronically and hoping that, and believing in that data.
Right.
What do you think?
But that's exactly right. And I think